اهلا بيكم وكل سنه وانتم طيبين. مره تانية جمعيه الشبكيه المصريه بترحب بيكم في برنامجها اليومي الجديد شبكيه اليوم رمضان ديلي ريتن ريسيبي. في البرنامج زي ما انتم اتعودتوا هنقدم وجبه دسمه ولكنها سريعه في موضوعات الشبكيه وكمان الوصفه السحريه لعلاجها. كمان هنتعرف عن قرب عن ضيفنا العزيز الأستاذ الدكتور أخي وحبيبي الأستاذ الدكتور احمد مجدي بدة، أستاذ طب وجراحة العيون في جامعة الإسكندرية، وأحد النجوم البارزة والمضيئة في مجال الشبكية مش بس في اسكندرية ولكن في مصر ومنطقة الشرق الأوسط. دكتور احمد مجدي ساهم في تطور وارتقاء جراحات الشبكية في الإسكندرية ومنطقة الدلتا ومصر، وأياديه البيضاء على جيل جديد، جيل يعني في مجال الشبكية. النهارده هنتناقش مع الدكتور مجدي في موضوع ماكيولر باكس، موضوع صعب ورزيل، انما مع الدكتور مجدي هيبقى سهل ومريح. اهلا بيك دكتور مجدي.
اهلا بيك يا دكتور محمود.
نحب نتعرف بقى، يعني انت اسكندراني طول عمرك؟
احنا اصلا العيله من المنوفيه، لكن انا من مواليد القاهره. وعيلتي كلها في القاهره، يعني انا الوحيد تقريبا اللي في اسكندريه.
دي معلومه جديده دي. عاده الاسكندراني بيتقهر، انما القاهري
لا، احنا الوالد كان
مختلف شويه. طيب يعني انت درست في اسكندريه؟ دخلت مدرسه
كل دراستي كانت في اسكندريه. في 4 سنين كده من اولى اعدادي لاولى ثانوي كان الوالد اتنقل سوهاج، فانا رحت معاه ال4 سنين دول ورجعنا تاني اسكندريه بعد.
قبلت.
ايوه بالظبط.
طيب طول عمرك كنت بتحلم ان انت تبقى دكتور؟
ايوه دي الحقيقه. يعني ما كنتش بفكر ابقى يعني في مهنه تانية غير الطب يعني.
لا يعني ما فيش اختيارات، هو الطب هو الطب.
فعلا.
طيب وامتى قررت يعني تدخل في مجال العيون وتبقى طبيب عيون؟
وانا امتياز الحقيقه. ان انا ما كنتش بفكر وانا طالب في الكليه ان انا ابقى دكتور عيون. انا كنت متاثر طول عمري بخالي الله يرحمه الدكتور محمد عبد الله، هو استاذ نساء في القصر العيني.
ده صحيح.
عارفه انت محمود؟ وكنت بفكر ان انا اخد نساء لغايه اخر شهرين في الامتياز، هو كان تمرين النساء. بعد اسبوع واحد من تمرين النساء انا هشتغل اي حاجه الا الشغلانه دي. فساعتها كان الاختيار بتاعي بقى ان انا اقرر حاجه تانية. انا كنت طالع الاول على الرمد، واخد جايزه الرمد في الكليه، وانا كنت بحبه كماده، فقررت ان ادخل عيون يعني.
طيب دخلنا ايه فتره نيابتك بقى؟ كان اخبارها ايه؟ نيابه لطيفه، نيابه سخيفه، كان ايه فتره؟
لا الحقيقه فتره نيابتي كانت فتره جميله. في الوقت ده كان الاسم بتاعنا العلاقات بين الناس كويسه جدا. والحقيقه ما زالت الى حد كبير كده. كانت فتره اتعلمت فيها كويس، اشتغلت كتير وتعلمت كويس. وهي دي يمكن الفتره اللي انا فكرت ان انا اتخصص في الشبكيه، لان انا في الوقت ده كان عندنا مشاكل في عمليات الانفصال الشبكي. كنا بنشتغل، كان في ناس كتير بتشتغل، بس انا كنت شايف ان النتائج برضه مش حلوه قوي، وان الموضوع محتاج ان في ناس تتخصص فيه اكتر.
طيب وانتهى الامر بقى، يعني ايه يعني الليرنينج كيرف والتيتشنج بتاعك في موضوع الشبكيه؟ هو واز يور منتور؟
الحقيقه في الوقت ده كان عدد الاساتذه اللي عندنا في اسكندريه بيشتغلوا في الشبكيه قليلين، بس كان في الله يرحمه الدكتور مدحت الحناوي والدكتور امين نصر كانوا بيشتغلوا. والحقيقه انا شفتهم هما الاثنين. وبعدين انا سافرت اول مره فرنسا، كانت منحه تبع السيديم لمده سنه. ورحت اعمل رساله الدكتوراه بتاعتي مع مدام ميري بونيه، كانت هي رئيسه القسم في لوبيتال دي لا كروروس. وكانت سنه الحقيقه مثمره جدا، لان ده كان تيتشنج سكول. هي اي نعم لهم هم اتجاه معين في الدايجنوزس والمانجمنت وكده، بس كان اهم حاجه فيها ان هم مهتمين جدا بالايفالويشن اوف كيسز والديسيجن فور سيرجري. السنه دي اتعلمت فيها كتير ورجعت. كان هم بيستخدموا التكنيك بتاع السليت لامب ماونتد على السيرجيكال مايكروسكوب، ويستخدموا جولدمان فيمر كونتاكت لينس، ما بيستخدمش الاندايركت اوفثالموسكوب في السيرجري. في عمليات حتى الريتنال ديتاتشمنت العاديه مش الفيتريكتومي. ورجعت قعدت سنه تقريبا اشتغل بنفس التكنيك، يعني بنستخدم الجولدمان فيمر كونتاكت لينس مع السليت لامب ماونتد على الميكروسكوب. وبعدين بعدها سافرت تاني امريكا، رحت ايموري اي سنتر، قعدت 6 شهور. في الوقت ده كنت رايح مع الدكتور مايك لامبرت، وهو برضو احد يعني اهم الناس اللي انا اتاثرت بيهم، يعني جراح ممتاز وشخصيه هايله علميا واجتماعيا يعني الحقيقه. ورجعت بقى وبدينا رحله الكفاح الطويله دي اللي انت عارفها.
فعلا كفاح. طيب ما فكرتش في الهجره خالص دكتور مجدي؟
لا خالص خالص، حتى وانا في فرنسا ولا في امريكا. الحقيقه دايما كان عندي احساس ان انا لو هاجرت هيبقى عندي شعور ان انا غريب، يعني هعيش طول عمري غريب، والشعور ده انا ما كنتش احبه يعني. وحتى الحقيقه في امريكا انت عارف كان دايما الناس متصورين انت جاي وهتقعد، يعني لا احنا مش هنقعد، احنا هنتعلم ونرجع تاني.
طيب تمام. قول لي بقى يومك الرمضاني اخباره ايه؟
يومي رمضاني في السنين الأخيرة كلها أنا بشتغل الظهر كده من الساعة 12 للساعة 5 عادة، ده وقت الشغل يعني. غير كده بقى الطقوس الرمضانية المعتادة يعني.
يعني في كده استرخاء في رمضان ولا في عمل؟
لا مفيش عمل غير من اللي هي الفترة دي من 12 ل 5، بعد كده بقى الاهتمامات الرمضانية المعتادة يعني.
امال اكلتك الرمضانية المفضلة ايه؟
أنا الحقيقة ماليش، يعني أنا باكل أي حاجة يعني ما بعترضش يعني على الأكل. فأنا يعني الأكل مش من هواياتي الجامدة يعني، لا.
طيب الحمد
اللي
لله.
موجود باكله يعني.
طيب اتعرفنا بقى على الدكتور مجدي وحياته الشخصية وبداياته، وعرفنا الدكتور مجدي ان هو وطني صرف، هجرة مش في دماغه خالص،
ما كانش.
ورجع علشان يخدم اهل بلده وبلاده، وفعلا خدمت الدكتور مجدي كتير.
الله يخليك، الله يخليك يا دكتور.
فاصل ونعود عشان نكمل مع بعض الجزء الثاني من البرنامج بتاعنا النهارده، وهو الجزء العلمي عن الماكيولر باكلز. اهلا بيكم مره تانية بعد الفاصل، ومع بعض في الجزء العلمي مع ضيفنا العزيز الدكتور احمد مجدي بدة، اللي هيكلمنا النهارده، هيتكلم ونناقش مع بعض الماكيولر باكلز. الماكيولر باكلز زي ما انتم عارفين موضوع صعب وشائك، ولكن ان شاء الله مع الدكتور مجدي هيقدم وصفته السحريه للتعامل مع المشكله دي. اتفضل يا دكتور مجدي.
بسم الله الرحمن الرحيم. I have been asked to talk about macular buckles, and in fact I will divide my talk into 2 points. The first point is the use of the endopump for management of myopic macular whole retinal detachment, and in fact this has been used for a long time before I tried. The first time my interest rise in using these buckles was in 2010 after seeing Dr. Carlos Mateo presenting the use of the endopump for management of myopic macular whole retinal detachment. For those who do not know the endopump, it's a rectangular shaped solid silicone plate, 5 millimeter in width, 2 millimeters in thickness, and it has 5 different sizes ranging from 21 to 29 millimeters. The endoplump has a circular button as shown in this photograph, 5 millimeter in width and 2 millimeter in thickness at the posterior tip to indent the macular area. The endoplump contains a titanium wire to keep it rigid enough to indent the sclera. It could be bent at surgery to give an adequate curvature. This video demonstrates my first case of using the endoplump for management of myopic macular retinal detachment. It is fixed between the superior and lateral rectus muscle. Drainage of subretinal fluid is done, fixing the buckle is done, and injecting air inside the eye to complete the surgery. It's a rapid procedure, probably takes 30 minutes to finish from the start. This patient has a myopic macular retinal detachment, and this is the appearance 1 day after surgery. Notice you can see here the indentation effect of the terminal button of the endoplump at the macular area. The subretinal fluid has disappeared completely 1 day after surgery. And this is the appearance 2 months after surgery. Mild indentation of the macula is seen at the OCT, and the retina remained attached. This is another case before surgery, and in the photographs down, you can notice the indentation effect in the OCT, and the retina is flat, subretinal fluid has been totally absorbed. And this other case having a large macular hole, and this is the appearance after surgery. Almost the fluid has been absorbed. This is 1 month after surgery, the retina is attached, and actually the procedure has some advantages, including it avoids exposure of the posterior sclera close to the optic nerve. So you don't need to go far posterior. It avoids suturing over the thin sclera in the staphylomatous area. It also avoids disincision of the oblique muscles. However, the procedure has problems. The first problem I encountered using these macular buckles was the localization. There is a definite inability to accurately locate the terminal button under the macular hole, especially in cases in which no drainage of subretinal fluid is adopted. Why is it difficult to localize it? Because you cannot see this terminal part. You put this button from outside, and you have no way to make sure that this is under the macular area. So you can notice this patient having myopic macular retinal detachment, and this is the appearance 1 day after surgery. Subretinal fluid is still there, and the indentation effect is temporal to the foveal area. So it was improperly located. It has been located away from the desired point. And the surgery failed. The patient has been readmitted again, and the buckle has been mobilized towards the macular area, pushed more posterior, air bubble is injected, and the retina has been attached. This problem is very evident in those cases in which you intend to apply a macular buckle without drainage of subretinal fluid. There is no way to make sure that you are in the proper location. In fact, this was my first modification for its use. After bending the buckle, I used a sharp needle to make a track in the back surface of the plumb. Through this track, a fiber optic light is inserted. So the terminal button is illuminated. Then we bring this buckle to the OR, apply it in the usual way. Take one pre-placed suture, don't tighten it, leave it like this, and then use the biome to visualize the fundus. once you apply the Brillium, you are able to see where is the terminal part of this plumb. You can see it here, temporal to the optic nerve head, but slightly below. You can move this button from outside, closer to the disc, away, move it up or down, until you make sure that your terminal button is under the foveal area. This way, I was able to make sure that the terminal part is under the macular area, and you are in the proper location. Inject air and remove the fiber optic light from the endoplumb and finish the surgery. So this is a myopic macular hole retinal detachment. This is 13 hours after the illuminated buckle has been put, 3 days afterwards, and 13 days after the retina is dry, flat, no fluid under the macular area. The OCT 13 hours after surgery demonstrates some fluid which was still present, and 3 days after surgery, the fluid has almost gone. 13 days, everything is flat. So the first problem using these buckles was localization of the terminal end of the bottom, and it has been solved by me by eliminating the terminal part of the endoplumb. The second problem was the indentation height. You cannot exactly adjust the indentation of the buckle under the macular area. So this is a patient having recurrent myopic macular hole retinal detachment under silicone oil. We brought this patient to the OR. We removed the silicone oil, used the illuminated buckle and locate it properly under the macular area, and then inject gas. So this is the appearance before surgery when the retina was detached. And this is 1 week after the macular buckle. You can notice that retina is dry. No subretinal fluid is there. 2 weeks after surgery, you can see the indentation effect of the buckle, and the retina remained dry. However, when we checked the OCT, the macular hole was still open. The fluid is definitely less, but the indentation effect is minimal in the photograph on the right side. And of course, 1 month later, there was recurrent retinal detachment. So the surgery failed. The surgery failed in this situation because the height of the buckle was not high enough to indent the macular hole. This is another example of recurrent retinal detachment after vitrectomy and gas. 10 days after surgery, the fluid was definitely less, but however, there was still fluid. And 2 weeks later, after surgery, the retina was totally detached. When we checked, the patient also has been brought to the surgery, used the illuminated buckle to locate it properly. 1 week after the episcleral macular buckle, the retina is attached. 2 weeks, everything was fine. However, when we check the OCT before surgery, this is the OCT before surgery, and this is the OCT 1 week after macular buckle. Notice the fluid has gone. However, the indentation effect is also mild, is not sufficient, which led actually to failure of the surgery and recurrence of subretinal fluid at the macula. So we have a problem here now. We need to solve this problem of the height of the indentation. How to solve this problem? In fact, I returned to the anatomy described by Professor Siam, who localizes the macular area externally by its relation to the insertion of the inferior oblique. According to the anatomy described by him, you can find the terminal long posterior ciliary vessels at extending from the inferior part of the posterior edge of the inferior oblique insertion towards the macular area. So in this video, you can notice the temporal long posterior ciliary vessels extending from the incision of the inferior oblique towards the macular area. This should be the site of putting your buckle. So we have to identify this first. Notice this patient who has recurrent macular whole retinal detachment under silicone oil. This is the appearance before the second intervention. So we expose the lateral rectus, the inferior oblique. We take a suture in the inferior oblique. Then we identify the temporal long posterior ciliary vessels and define the position of the macula, which is, according to the anatomy described by Professor Siam, 8 millimeters posterior to the inferior oblique insertion. And then go as usual, put the macular buckle, bend it according to the site of the macula. So if you find that there is a large staphyloma, you should bend the buckle more. If you find it a shallow staphyloma, bend it less. And put the terminal button after elimination of the buckle. So this is how to put the buckle and to bend it accordingly, and then push it, push and make a mark externally on the side of the anterior edge of the buckle. Do paracentesis, illuminate your buckle, and then insert it and fix it. This is the appearance of the patient after failure of the initial surgery. And this is 2 days after surgery, the way I have described. You can notice here that the terminal end of the button is at the foveal area. However, some fluid is still present on the nasal side of the macular area, between the disc and the macula. This is the OCT appearance after putting the macular buckle. Some fluid is present on either side of the buckle. However, 1 week after surgery, all the fluid has gone away and the retina is flat and attached. Look to this patient who has failure of retinal detachment surgery after vitrectomy and silicone oil tamponade in this very high myopic staphylomatous eye with fluid. This is 1 day after surgery. Immediately you can notice the amount of subretinal fluid has decreased. The fluid which was seen temporal to the foveal center is much less. And then 10 days after surgery, you can find the retina is totally attached, dry, and all the subretinal fluid has gone away. So this is about the first modification I've done for the macular buckles. Then we thought that, I thought that there is also another difficulty in fixing and taking sutures in those very high myopic eyes. So I decided to try to use something instead of taking sutures at this very high myopic eye. And instead of sutures, I have tried to use cyanoacrylate, what's termed histoacryl blue, to fix the buckle to the surface of the sclera. And unfortunately, at this time, the endoplumb is no longer present. You cannot get it from the buckle.
Well, this is my question.
So I have decided to manufacture a buckle from the materials present in the OR.
Dr. Mejdi, thank you very much for the fantastic presentation. And these are very difficult cases. I mean, is the macular buckle now available? How do you get hold of the macular buckles now?
The endoplumb is no longer available in the market. However, I have manufactured a macular buckle from the sponge present in the OR and from the tire. We manufacture a buckle from both of these, and we use histoacryl blue to fix them to the surface of the sclera.
Okay, and I mean, is the macular buckle your preferable or preferred technique for the management of myopic macular whole detachment now?
It is a preferred technique for myopic macular whole retinal detachment associated with posterior staphyloma in very high myopic eyes. This is the solution for these very difficult cases. However, myopic macular whole retinal detachment, which are not associated with posterior staphyloma, can be managed by vitrectomy, ILM peeling, gas, or silicone oil. However, in those very high myopic eyes with posterior staphyloma, ILM peeling is very, very difficult. In my hands, it usually doesn't work. Although in the hands of other surgeons, it might work. However, in my hands, it doesn't work. So this is the preferable alternative solution.
Excellent. I mean, okay. And finally, we want your recipe. You want your recipe for macular buckles.
The recipe for macular buckles is the method of choice for management of myopic macular whole retinal detachment associated with posterior staphyloma and those symptomatic cases of myopic foveus cases. These buckles usually do work significantly in these cases, achieve a reasonable success rate, and I do believe that they are superior to ILM peeling in these cases. Cases of myopic macular whole retinal detachment not associated with a buckle can be solved with vitrectomy and ILM. Not associated with the staphyloma can be managed with vitrectomy and ILM peeling.
Excellent recipe. وصفة سهلة بس مش سهلة خالص. شكرا دكتور مجدي. في النهاية I'd like to ask you what is your advice to young ophthalmologists interested in vitreoretinal surgery?
Those who are interested, they have to know that this is a long way to get experience in this field. However, I motivate everyone who finds in himself the motive to go through this field, to do it, to be patient, and to know that there is a long learning curve until one gets expert. And even when he becomes expert, he will always face problems.
True. Well, thank you very much, Mejdi, for your excellent Ramadan recipe. الوصفة السحرية لمشاكل الماكولر باكلز. يعني سعدنا بوجودك معانا دكتور مجدي.
انا اللي متشكر ان انا كنت معاك، وانت عارف ان انا دايما ببقى مبسوط وانا معاك يا دكتور محمود.
كل سنه وانتم طيبين ورمضان كريم، ونشوفكم دايما على خير، والى اللقاء في حلقه جديده ان شاء الله.
ان شاء الله.